Off. We're live.
All right, terrific. Thank you, Nellie. Good morning, everyone. It's May 21st, hard to believe. This is a joint meeting with House and Senate Senate Health and Welfare and House Healthcare. I'll get used to that later. So good morning, everyone. Thanks for being here. And I just wanted to say thank you to all of you who testified to our Health and Welfare Committee yesterday on the bills that you've sent over to us. You've done a lot of work, and we look forward to taking up as many of those as we can, working on them. So today we have some work to do on our health insurance coverage for telehealth and telephone services. And Jen, we have the same draft that we looked at last time, but maybe we could, two things I think that would be helpful to do. One is to go through the draft again, because I'm finding that there's a lot of distance between when we do something and when we come back to it. I mean, there's a lot of other, issues involved. So Jen, let's go through the bill. And then the question I would ask Bill is, has your committee gone through the other sections of Act 91?
No.
Okay. Well, maybe we can talk about that afterwards. All right. So Jen, why don't we go through the bill that we have in front of us?
Okay, great. Jennifer Carby, Legislative Counsel. So this is, it's currently listed as drafting request number 20-0981, and it's draft 1.1. And this is an act relating to access to, we'll say to, healthcare services delivered by telehealth and telephone. The first section moves up the effective date for the health insurance coverage of services delivered by store and forward means from January 1st, 2021, which is what it was in Act 91, up to May 1st, 2020, which is the date that the DFR emergency rule had the store and forward coverage begin. And just by way of recap, you heard at your last meeting on this from DVHA with some concerns and interests around Medicaid coverage, which did not, was not subject to the DFR bulletin or DFR emergency order because they're not regulated by DFR. Section 2 creates a DFR working group to develop recommendations for health insurance and Medicaid coverage of healthcare services delivered by telephone after the COVID-19 state of emergency ends. And it specifies who would be on the working group. It would include representatives of DVHA, health insurers, the Medical Society, Bi-State Primary Care, the VNAs of Vermont, the Vermont Association of Hospitals and Health Systems, the Office of the Healthcare Advocate, and other interested stakeholders. And it would have the working group provide its recommendations by December 1st, 2020, to your two committees and the Finance Committee with recommendations for ongoing coverage of healthcare services delivered by telephone. And then it would, for the first part, the effective date for store and forward, apply it retroactively to when Act 91 took effect, as though that was what you had passed the first time around, and the rest would take effect on passage.
Okay. Questions for Jen from the committee? All right. So I think
I have a question.
Go ahead, Bill. Yeah.
So just to make sure I understand, because I think one of the issues is how long we continue to have it in place. Is that spoken to in the bill?
No, the bill does not currently address, it has a working group think about and make recommendations on coverage of healthcare services after the state of emergency, but it does not actually extend any requirement for coverage of telephone delivered services after that DFR order ends, and the DFR emergency order runs with the state of emergency.
And can you clarify, do you mind if can you clarify as well between the bulletin from DFR and what's in the bill, whether there's an endpoint or language about an endpoint for store and forward?
No, once the store and forward takes effect, it's in effect ongoing. So it's a statutory requirement. It would be in statute and continue as a coverage requirement going forward. So it's not tied to the state of emergency.
So
And this
that's a good
based
question.
on the DFR bulletin, which is,
Right.
doesn't apply to Medicaid.
Right.
Right. So a couple different pieces. The DFR, and I think I called it bulletin. DFR emergency order started store and forward earlier than the date in Act 91, which had said January 1st, 2021. So DFR moved that up to May 1st in their emergency order, but that coverage requirement for store and forward under the emergency order only applies to health insurance and only applies through the duration of the state of emergency, unless you make the change in the bill to move the store and forward effective date up permanently.
Thank you.
Other questions? So the question is, I think Bill's question about a telephone is a good one. If it ends with the emergency order, is there any reason to have it extend for a 30 or 60-day period post order?
So I think I think this is the issue that the advocates have brought to you as a concern, that there would be a period between when the state of emergency ends and when you might come back and enact legislation based on recommendations next year in 2021. There would be a period where there wouldn't be any requirement for coverage of services delivered by telephone. So it's a policy question for you whether you want to continue that. I think there are different perspectives among different stakeholders, but those in the provider community and others are asking you to extend that beyond the end of the state of emergency. And I think in some cases extend it through the end of FY21 so that there would be continuous coverage while the various stakeholders work out the path forward.
Okay, I've got two people with their hands up, Representative Page and Representative Christensen.
Well, I was just going to ask, why couldn't we extend this state of emergency, the benefits that are provided during this period of time up to or beyond the working group meetings to determine what they're going to do? Is there a negative consequence by doing that?
I think you would hear from the insurers that they believe there is. I think there is, and I think there's maybe concern among some people. I won't try to figure out who they are, but about whether services delivered by telephone, whether services are appropriate for delivery by telephone, which services are appropriate for delivery by telephone, and concern about drawing that line either too narrowly or too broadly.
So is there also an issue around the federal government and HIPAA? Because right now, during the federal emergency, HIPAA, the connections
So the HIPAA piece is really telemedicine. That's the interactive audio video, not telephone. I think there's a telephone issue for Medicaid, for DIVA, because CMS may not permit them to reimburse for services delivered by telephone after whether it's the federal emergency declaration, federal public health emergency declaration, or some other period. But the HIPAA piece, I think, is really more the telehealth, particularly telemedicine part of it.
Okay, thank you.
That's not what's addressed in the bill.
All right.
So Representative Page, did that address your question? I mean, it's a continuing policy question for you all to wrestle with, but I think that's exactly the question you're being asked.
Okay, and are there, I would assume there's more positive aspects of extending this than there are negatives. Is that correct?
I will leave that up to the committees to decide.
Okay, thank you.
That's a good question. Representative Christensen.
I think it's along the same lines as Representative Page. I've talked to several doctors on telephone and telehealth, and they're concerned that it's going to stop and start. They like it a lot. It's not good for all professions. But they really were concerned it was going to stop and start. And also I'm concerned about people who do not have the connection for a telehealth, that especially some elderly people who just aren't up to speed or don't have the connection to figure out. So I personally would like to see this extended to the end of the year, and we can make changes based on the working group, then just stop it. Yeah,
Is that Morse code?
that's not me.
right.
Come on.
Oh, come on, you sending us another Zoom invitation? Andy?
No, it's not me.
All right, Representative Donahue, you have your hand up.
Since we've jumped into it, I mean, I really agree in terms of the concern about it may not be appropriate for some types of services. You know, that goes to kind of scope of practice and the provider knowing when it isn't appropriate to deliver it that way. So I'm not convinced by that concern.
Good point. Yeah, and part of it is discretion of the provider. Exactly. Other questions or comments? It seems like we're in the middle of discussion. I think now we're on that section 2, or we're actually on both sections, and determining if there's a transition time for telephone before we get recommendations back for maybe legislation.
So can I,
Yes,
don't we have two separate questions that we need to address? I think what's being addressed is the issue of telephone and how it applies particularly to commercial insurance. I think the DIVA question having to do with Medicaid perhaps has to be thought about a little bit separately, because it didn't start at the same time. They're proposing, as I remember from briefly reading something this morning, that it be retroactive to, or that it be effective July 1 for, oh, that's not even telephone, that's storing forward. I'm getting
Yes,
things
it
wrong.
is.
So there's a number of things, there's layers of things that need to get sorted out, but I'm just going to say it's so,
Right.
okay.
So
So-
I mean, what I was going to suggest is let's focus in on the telephone, and you're
Yeah.
right, DIVA is different from private insurers, and then maybe we can sort that one out, and then.
Right. So maybe one piece at a time. And I think what you're talking about now is telephone.
Yes.
That's
yeah,
what people have been commenting on. Is that fair to say?
Yes.
Okay.
Representative Houghton had her hand up.
I'll just say from my standpoint, I think that people are going to be really still worried to go to their doctor physically for quite a bit of time. And I'm concerned that people are not getting the healthcare they need. So if we can extend the telephone piece for those people who feel comfortable with that until we hear back from the workforce, or whatever we're calling the committee, I think it'd be a big benefit to the people who still need healthcare and are scared.
So let me ask sort of the question about, if we were going to extend it, is there anyone who would have significant concerns about extending that, knowing that we have to parse out DIVA from private insurers? But is there anyone here on our two committees who might have reservations about some transition period until we know what the recommendations are? Oh, good. That's good. No, seriously, then
Yeah.
that gives us the next question, which is, if that, then how long, to what extent do we continue it? And then I know that there are folks on the call from VMS and the bi-state who would like maybe to comment on this, and that would be also helpful. I don't see, I suspect that the private insurers are out there listening to this, and so we need to hear from them. There's no question about that, as well as DFR. But so at this point, if we were going to make a recommendation, how much time would it be? And if the committees don't mind, I would ask the VMS and or by state. Helen is here, Helen Laban, and Jessa Barnard is here. Are you interested in making a comment about where we are at this point with the telephone piece? I'll start with, I see both lights went on, so who wants, Jessa, go ahead, and then Helen.
Sure. Thank you very much. Jessa Barnard with the Vermont Medical Society, and thank you for inviting us this morning and taking up this issue. This is a great, I'm really appreciating this conversation. This is exactly where we are and what Bi-State and VMS have really been talking about with each other. So hopefully we'll say the same thing, I think, which is we absolutely are with the committee that we think the current coverage should continue long enough to be able to get the recommendations back and implement those recommendations from the work group. Our concern is really just about, frankly, legislative timing. If the recommendations are coming to the legislature at the beginning of next session, obviously, as you know, that could take until, if that requires legislation, those changes won't go into effect until the legislation goes into effect. So again, to Representative Christensen's comment, our members are really concerned with the flipping the switch on and off as we're making changes. And so our request would be to keep, basically keep the status quo until the legislature would have time to implement or enact something different, which would be really the end of next fiscal year, most likely. So that would be our suggestion, our request to the committees.
When you say next fiscal year, you're saying what would the date be?
That would be, what would that be? End of June 2021, if I have my math correct.
Yeah, okay. Helen Laban.
Right, we would agree. I appreciate the optimism in thinking that you'll get the working group results on December 1st and instantly implement new systems. But realistically speaking, there's sort of two big buckets of concern that we're looking at here. One is, as Representative Hoden pointed out, providers are really concerned about folks avoiding care, delaying care, not being able to access care. So they want to maximize the tools available while there is that anxiety out there, and beyond for all the other reasons. So there's that continuity piece, but there's also the piece of, especially at the federal level, there's been a lot of switching back and forth through different systems of reimbursement. It's causing a lot of confusion and anxiety among providers who are spending time worrying about understanding these systems that they would like to spend worrying about serving their patients. And so having some security that this will be in place through the end of the process that it takes to review the recommendations and implement new systems is going to be incredibly important and frankly very relieving to our providers, that they know they have some sort of stability there as they figure this out. And also that stability helps get to the concern that I think we all share, that this is a new way of accessing care, right? We need clinical education, we need training, we need best practices. It buys them the breathing space to engage in those as well, while we sort out the reimbursement side of things. So certainly would like to see that extended through the end of June 2021, just to give us that runway to implement appropriately and somewhat calmly in a very non-calm situation.
Okay, thank you. Thank you both. That's helpful. I think we'll probably hear from our private carriers, maybe a slightly different request, but I think part of the issue, of course, is the cost of doing that, but it could be that the cost is null.
There's also a cost of not doing it.
of
And I
not
think we
doing-
need to take that into account,
Thank you.
which is the cost of the impact on healthcare, the costs for failure to seek medical care or the inability to seek medical care through what we might traditionally say, now traditionally, telemedicine that includes video. And we know that that's not accessible to everyone, either because of broadband nor because of technology or familiarity with technology. So I think there's a cost both ways.
Thank you. That's a very good comment. Senator McCormick and then Representative Durfee.
Thanks. I want to ask both witnesses, are you comfortable with the level of specificity in what's being contemplated here? Are you comfortable that we are not getting into the area of micromanaging? You know, legislation it seems to me ought to have a finer point than the Constitution, but a much broader brush than regulation, and in particular as regarding a self-regulating profession that also makes its own protocols. Do you feel that we are being adequately restrained?
Can I just ask a clarifying question? Are you referring to the language creating the
Yeah.
work group around the DFR work group?
And everything that the work group is looking at, that it's charged with investigating and figuring out.
Well, this Jessa with the Vermont Medical Society, I would just offer that DFR has been doing a good job of already holding weekly stakeholder calls and discussing a lot of issues around all of the coverage changes that have been happening over the past couple of months. So I think this is already well on the radar. In fact, at our meeting I'm losing track of which day it was, on Monday, that group already started talking about some of the audio only issues. So I think DFR, well, not to speak for DFR, but they're well aware of the questions the legislature is contemplating and that the providers and payers are thinking about. So I think it's, in my opinion, fine to leave this fairly general, and that work group will kind of define the issues as they go along and be able to address them.
Yeah, and this is Helen Laban from Bi-State Primary Care Association. I apologize, I did not introduce myself before. I agree with Jess's assessment. I would say that it's, in the world of telehealth reimbursement structures generally, it is a particular problem in terms of specificity because the playing field is changing so rapidly and best practices are changing so rapidly. So being less specific is often a virtue in this case, because it leaves you, it avoids the problem of being suddenly caught being 10 years behind, right? Which we would prefer not to do. And in the case of this particular working group, I don't think that there is much disagreement on what the issues are in terms of considering reimbursement. We have been working well with DFR and others to frame it out, and we are bringing in outside assistance as well with folks who've been thinking about this for a long time. So we're working quite well in the framing, and I think it's will go well as currently phrased.
That's all I have, Madam Chair.
All right, thank you. Representative Durfee.
Yeah, thank you. Senator Lyons, you mentioned a moment ago the costs of cost of telephone, I think, or at least that's what I'm thinking about, of having the payers reimburse the providers. And my question is whether we've already heard, or whether it would be helpful to hear, I guess, what those costs might be, so we can quantify what the impact is on the system. I mean, it strikes me that the need to provide, we don't want to discourage patients from seeking care, and ideally the providers wouldn't be denying that care even if they weren't being paid, but we don't know that that's the case necessarily. I guess so I'm thinking about this as what's the financial impact what would the financial impact be if we were to say, definitively, yes, providers will be reimbursed for whatever period of time?
I mean, that's a really good question. That's exactly the question that we should ask, I think. Not that it will change our interest in ensuring access to care. But the issue is, as I think Representative Donahue said, that providers do have some discretion in who meets by telephone and who doesn't. And I think certainly during the next several months, while people are apprehensive or maybe exposed to COVID, that having the telephone option makes a lot of sense. I think we should go back and listen to providers and DFR one more time before we, say move ahead. But you know, I'm thinking that this makes a lot of sense in terms of patient access and continuity for providers. But we don't necessarily, and if we learn that this is going to bankrupt a private carrier, then we shouldn't do it. But I doubt myself that that is the case, and that's the role that DFR plays in the conversation. And we'll hear from MVP and Cigna and Blue Cross and Blue Shield. I think we need to invite them to a Zoom to do that. It's a very good question.
Senator-
Representative Donahue and then Representative. Whoops, somebody, it was Jill Olson wanting to speak. Who was that? I don't know who said that.
I apologize, Senator Lyons. That was I did not know if there was a question in there that to the providers prior to bringing in the other payers to speak to that issue, because that is something that we have been tracking. If you would like to hear what we have found so far, but I also don't want to interrupt
We
your.
would. Here's what my suggestion, Jill. Thank you for, we have talked with
Helen.
both Jessa and Helen, but what I'd like to do is to have Representative Donahue and Representative Lippert ask their questions or give comments, and then we would love to hear what you have to say about the work that you've been doing. Thank you. So Representative Donahue.
Thank you. I guess this is really to the question of the on and off and the different systems, which of course, as an overall has been the bane of our healthcare system for a long time now, that, you know, different insurers, different policies, different pre-authorizations and all those. So I think it's in everyone's interest for consistency, but reminding ourselves that they still have another whole layer of inconsistency, and that is that all of the self-insureds aren't covered by whatever we do. And also they've got Medicare operating on different rules. So, so that may be an added reason that we want to minimize disruption for the, you know, small part, or, you know, it's only one part as it is that we're doing. I just found out this week, Medicare is not covering for group therapy by telemedicine. And that's a big issue and problem for providers being able to use that effectively. The you know, Medicaid and the private insurers are covering it, but then they've got a group of folks it's not covered for. So it's probably another reason that we want to help in reducing the degree of some are, some aren't, some of the time, not other times.
So you bring up the very important issue of alignment, and how can we possibly align all of our insurance programs, whether they're public or private, for different
We
rules.
can't, but we can't, but we do it as much as possible.
We keep trying, right? We keep
Right.
trying. Representative Lippert, thank you for that.
Yeah, and I would just maybe pick up on what Representative Donahue said, but my comment is that I think we're at the point where I think we should put a proposal on the table and then have others respond to a proposal rather than continue to churn around about a possible proposal. And I agree with you, Senator Lyons, and I think we haven't articulated the specific proposal. I would suggest that we put on the table a proposal that would extend the telephone consultation as through the fiscal year of FY21, and let that be the proposal that then others because I think it brings continuity, it brings alignment, and we know that self-funded will in many cases adopt what is done for commercial. We can't require them to, and then we can talk about Medicaid, and we have nothing to say about Medicare, so we can't control.
Right. So yeah.
But anyways,
no.
I think we're at the point where a proposal should be put on the table and then have others respond to it.
Okay, good suggestion. And knowing that if self-insureds didn't respond, that the patients who are insured by them would certainly have something to say about it.
Right, yeah,
Um,
the market
so
will speak.
yeah, we like market-based decisions. Jill Olson is here and is chomping at the bit. Jill, can you help us understand what some of the financial issues are related to the telephone piece?
I'm not chomping at the bit.
Okay.
I think the telephone, as I understand it, and this is actually an issue that I think all providers have. It's definitely not limited to home health, and actually, I don't think we're even the primary. We maybe even the ones most concerned about it. But essentially, there are lots of places in Vermont where we know we can't get service to do video visits. I mean, so if we can only do telehealth when we have enough bandwidth for video, we're going to leave out some of our most vulnerable people. I think that's the primary concern, and I would, Jess or Helen may have more to say about that.
Yeah, Senator Lyons, sorry, that was me who was chomping at the bit. I did not mean to put Jill on the spot for that.
Okay, I'm sorry. That's really, this is what's wrong with Zoom. You can't tell who's sitting on the edge of their chair.
Well, we're usually all sitting on the edge of our collective chairs. So I was simply going to respond to the previous question about, because I do want to recognize the concern about extending the audio only through a longer period without having the final system in place, and concerns about the potential for that to drive up costs. I will say that these are not like the highest cost element of your healthcare system, right? The 15-minute call from a patient who needs to talk to a provider is not a huge cost carrier, but being sensitive to that, we have been checking with provider groups and regularly on our telehealth calls just to see what this is doing to volume. And during this transition period, we definitely are finding that it takes longer to do the telephone calls because it is new, because there's a lot of reviewing patient needs, talking through whether they should come into the office. If there is anxiety about that, talking through that. So there's a lot of more work that's going into the audio only. Hopefully we eventually get more efficient, right? And 5 years out, it is much more efficient. But in terms of the question of extending through the fiscal year 2021, having had the conversation with concerns about driving up costs through the audio only, we don't think that that's a concern. There's a lot of work that's going on behind the scenes behind these calls, and we don't see a major uptick over the next year. So the payers may have a different perspective on that. And I do know they have concerns in the long term looking far out into the future. But as you discuss extending through the end of fiscal year 2021, we have been sort of ground checking that in terms of costs, and don't think that it will be more expensive.
Okay, that's helpful. Thank you. So that's your ballpark. It's not more expensive. You got it?
That could be summarized as I don't think it's going to be more expensive, correct?
Okay, so let's do this then. Now we've gotten a recommendation, a proposal from Representative Lippert to extend the time frame for telephone only until June 2021, June 30th of 2021. Are there any who would oppose that going into the bill for purposes of, we're going to have to have the private carriers, and there's no question. And we may also like to hear from DVHA and what is possible there. I don't know. Certainly depends on the federal government. So is there anyone who would not want to see that go into a draft form? Wow. Okay, we're good. Well, Jen, can we put that in then?
Yes, but I'm going to need some more specificity from you, because right now all that's in your act is that DFR may adopt emergency rules on it. So I don't know if you're looking to extend DFR's rulemaking authority, direct them to extend their rule through that date, put the language from the DFR rule in, or what you're looking for. I'd also point out that the DFR rule does require the same reimbursement rate for services delivered by telephone as in person. And that may be part of your proposal, but I just wanted you to be aware that that was part of
Right.
it as well.
That is the issue, is the reimbursement rate for telephone only, and that's the concern that comes to us from in particular from the carriers. And that's why the working group is there. I mean, to determine which patients are covered by telephone and how much how much is the reimbursement. I would suggest, and then we can open this up for further discussion, but I would suggest that we put in the June date for a continuation of the emergency rule, DFR emergency rule.
Okay.
Without spelling it out. Now, what do folks think about that? I mean, it's just my suggestion. I
That
see
covers
a
the
hand,
reimbursement
Representative
issue.
Donahue.
I'm
Yeah.
sorry.
Right.
Yeah. Representative Donahue.
Yeah, I'm just agreeing. I think for the purpose of putting out a draft, we go the full extent, putting that as the statutory criteria through that date. And if there are huge concerns, we may want to say, well, partially, we may want to pull back a little bit depending on the testimony, but I think that should be the starting point.
And
Okay.
would you just continue the whole DFR rule, or do you want to pull the telephone piece out of it? It's their rule is coverage of services delivered through telehealth, telephone, or store and forward means. So some of it is sort of mixed in together, or may overlap or duplicate what's in statute, which that part's not a problem.
Yeah, I think.
Yeah, I thought we were going to leave the telehealth as we've drafted it, setting aside Medicaid for now, but leaving that as going into place, not time limited. Just the telephone being the piece that we now want to extend, put in statute as extended or sunsetting in June of 2021, pending the work group recommendations.
Right. Well, for example, the DFR rule applies to both health insurance plans and workers' comp plans. So I'm just trying to understand exactly what it is that you want to carry forward. So we're carrying forward what you want, and I may need help from DFR in understanding if we just tell them to extend the telephone pieces, are there other parts that get that would drop off at the end of the state of emergency that aren't covered in your telehealth statute?
Well, we haven't had that discussion yet. I think that's we were trying to work through the layers, and first it's a telephone. So I mean, that's my take on it
But
at this
I
point.
think what Jen is saying, that the telephone is linked to some other things.
I understand.
Yeah.
Right. The
So-
DFR rule is covers a lot of different things. So if you're going to extend direct that the DFR rule itself continue, that's certainly pretty easy
no.
drafting, but I don't know if the result is broader than you intend.
I think we want to extend the emergency rule related to telephone
Well, it's
coverage.
part of, right, but it's part of the same, it's all the same rule.
So we can't pull it out.
I think I need to understand what your purpose is, and if you're specifically not wanting to extend the other pieces of it, then we'll have DFR adopt a new rule. But if
I
you're
don't
just
think we-
looking to extend this status quo, which includes workers' comp and other things other than telephone,
Okay,
I just
I
want to
get
make
it.
sure you're aware of it.
we get it. Okay, Jill Olson is now at the edge of her seat. Go ahead, and then Representative Houghton. Go ahead.
Hi, I just wanted to make one comment, which is that the Provider Alliance did recommend that you direct that the entire rule be extended. So that was our recommendation, for what that's worth.
Okay,
We went around and around on this too, and that was our recommendation, that the rule, that DFR be directed to extend the rule.
okay. All right, we'll have to understand what the implications of that are, but if it means if it sounds like it's a chore to extract exactly what we want. So we'll come back to that. Representative Houghton.
I was just going to say the same thing, in that maybe this conversation needs to be continued when we talk about Act 91, because I think it all rolls together.
So right, that was an issue. I'm gonna ask us to do something that you may not want to do, and that is this. When you look at Act 91, the recommendation was for us to extend all those provisions. Senate Health and Welfare did go through each of the provisions with Jen, albeit we did it once and fairly quickly. But there are some that, for example, section 3, 14, 15, and 16, and probably wouldn't be something that we would continue, but there are others that certainly would continue. And I know that I don't think the House has had an opportunity to go through all those sections and kind of triage. So the question I have for all of us is, do we want to continue to work on this bill and to look at all of those sections with an eye to determining which ones can be continued? And if we do that, we're going to have DFR in, and we'll have to have we'll have the Star Wars Alliance in, and we're going to have the private carriers in, and probably DEVA, so they're all in there. So Senator Cummings, did you turn your mute off for a reason?
Do we know what DFR intends to do?
We have not asked them that question, and that's why we would want to have them in to do that.
Yeah, before I mean, it might know what they intend to do before we tell them what they're going to do might be helpful.
Well, their emergency rulemaking authority on telephone and some other parts is only valid during the state of emergency, because that's what Act 91 gave them. So I think their intention is that the rule ends when the state of emergency ends.
Right.
What they think about continuing it, I think, is what you should hear from them.
Yeah.
So let's do this. Let's Senator Ingram.
Yeah, thank you. Well, it just seems to me that we want to be adding more stability to this whole situation rather than making more changes, and just extending the status quo seems to me to fit that bill and would make life easier for everybody. But anyway, that would be my inclination anyway.
Yeah, I think there's an interest in having that happen. We want to make sure that we don't step into some unintended consequences, which is why we want to go through those sections and have DFR in to talk about, and maybe OPR as well, because there's some pharmaceutical stuff in there. So I like your suggestion, Senator Ingram, and I think we should probably pursue the concept of extending as much of Act 91 as we can to keep things on an even keel. And also knowing, we don't know how long the state of emergency extends at all. And we don't know how long the emergency is going to be with us, how long when the surge is coming and all the rest of it. So we don't want to have to rush back into session to extend an emergency rule after the emergency rule has ended. I think that all of those things fall into our looking at all of this completely. So because I think this is a really important bill. I think of a lot of the bills that we've been looking at, this one really rises to the top, and we don't want to lose sight of that. So, Representative Lippert.
Well, I'm just going to agree generally, and I think that we should start from a proposal at this point in time that the elements that are in the DFR emergency rule be the basis for what we extend through that period. And then I think I would recommend that be the basis of our proposal. And then someone needs to persuade us to the contrary, or some element should not be included, rather than us having to go through and identify each element of that emergency rule. I think what Senator Ingram said and others have said, continuity at this point in time is in the interest of patient care. It's in the interest of providers. It's actually I think it's broadly in our interest. And so I think Senator Cummings' question is a good one, but I think they don't have the authority to do what we have the authority to do, which is to say this continuity of what you've included in your emergency rule is what we recommend should happen through June 30th of 2021. And then have that be the basis for further comment from witnesses.
I want to bring up, though, the comment that Representative Houghton made and that we have looked at in our committee, and that is the request of sections 1 through 26 being extended as well. And so while the proposal might be to extend the emergency rule, there is significantly more in that bill, Act
Yes,
91.
I understand.
So,
But I'm just trying to get to the issue of the emergency rule, which
okay, we
there was
got to
some
the
debate
emergency.
about what part of the emergency rule shall we extend, what shan't we
Okay.
extend. That's on my proposal.
Are we
would be extend the
Okay,
emergency
good.
rule in its
I thought we
entirety.
had already decided that. I'm sorry.
Oh,
So
well,
let's
that's-
let's
wasn't
decide
clear on
that one. Let's be clear. Is there any concern from anyone about extending the DFR emergency rule until 2021 as it is, as a proposal? Anyone want to push back on that at all? It's a proposal and we'll hear testimony. Okay, good work. That's done. Then the next question, and I guess I stepped too far ahead and I apologize for that. The sections 1 through 26, some of which we may not want to include and many of which we will want to include, but I think before we make that decision, you guys, the House needs to go through those sections.
Could I make a request on that? If the Senate committee has recommendations about if you've come to conclusions about which sections should be extended and which might not be, that could be helpful information for us in beginning our analysis.
We
so that
haven't
we
made
know
it-
where we would be in alignment or not in alignment. And if you have
Yes.
not, then, but if you have, that I would ask that be articulated for our committee's information.
So I can tell you that as we went through the sections, there were some that as we listened to Jen and went through the summary of the sections, there were some that really probably didn't fit, and that would be section 3, section 14, section 15, section 16. There may be those who want to argue for those.
I think most of those were statutory. My
Yeah, those
explanation,
were the statutory ones.
not
right.
all of them, but some of them are statutory. They don't require extension. They're just, the law was added or
The law is-
changed and it goes forward. But there
And
are, I
then-
think, a few of those that the committee had policy questions about continuing.
Yes, that's right. So I can't give you
Well, without the, I'm not wanting to
I
put you on
can't
the
tell
spot
you
this
what
minute.
we agree, what we have decided. We haven't decided.
Okay.
So we'll go through again. Our schedule is pretty full next Wednesday, but maybe there's some time we can schedule next Thursday to come back to this bill, because that seems to be the day that the two committees can work together. And my request is that before we do that, you guys take a minute to run through the sections so that we're all ignorant in the same way. It's a lot. There's a lot there.
Okay.
Okay, so Jen, any other comments or questions from anybody? Okay, we've gotten through, I think we've done a good job on the telephone piece. I think that's helpful to have a draft proposal. I think we'd like to get to some place on the other sections of Act 91. Please, all of us should probably go back through that, and I'll schedule some time with Jen so that our committee can go through. Your committee will probably want to go through, and then as we get to next Thursday, we'll come back and be able to do two things. One, take testimony from the interested parties, and two, to identify those, probably in the reverse order, identify sections that we'd like to include in the bill.
Can I just mention that it seems like this is really a priority bill for both of our committees, as a pick to following up on the work we did initially together, in the emergency. And I just want to make sure that we're aware of the timeframes in which, you're going to need to move it through the Senate, and then it's going to need to come to the House, and it's going to need to get in the queue for getting out of getting it out of our committee. Once we do that, won't, I don't think, be difficult, but there's going to be a queue of getting onto the House floor. It's not going to go necessarily immediately to the floor, because there's a lot of committees that have things in a queue. So I just think that if this is a priority, we should just be aware of that. Plus, we have the budget pressing down on us, and we're going to be asked to make room for that. So which we will.
So here, so what I'm hearing you say is that we need to work independently and together at the same time.
Right.
Yeah, and I think that our committee can do that. We can go through those sections, and I'm going to ask my committee right now to please go through those sections of Act 91 and look at the ones that we need further clarification about, and then which ones you think are absolutely critical. And we'll try to come back together. We may be able to do that as early as Tuesday, because after we're off the floor, we only have time for discussion. So let's target that Senate Health and Welfare to look at that bill for next Tuesday. And Jen, I hope that you'll be able to help us with that a little bit. And then we'll on Thursday, we'll try and get back together and sort out where we are. I understand, Bill. The issue here is that this bill, to me, is a COVID-related bill. And
It is.
priority.
I agree.
Absolutely. And so if there's any queue, it steps into the front of the queue.
Well, I agree.
Yeah.
I don't make that case.
Me too. Okay. Thank you. Anything else on this bill? William, anything else on this bill? Oh, okay. Anybody else? I think we all want to make something happen, and we will. Lori, Representative Houghton.
We still need to talk about the DEVA store and forward piece.
Sure, go ahead.
Yes.
Well, I think there was some discussion during our last meeting that we were all a little surprised they weren't covering it. And I believe we all received some notification today of a proposal from them to, start as of June or July. I want to make sure that something gets in the bill that store and forward is covered through Medicaid as well.
Okay, I haven't seen that email.
Came very early this morning.
Yeah.
Oh, why did I miss it?
Yeah.
I goes up at 6 o'clock looking at email.
Yeah,
Okay.
so DEVA is proposing that they turn on the two codes, and then asking us to put forth a requirement to have them come back with a report. So we might want to hear from DEVA just to close that section out and hopefully move forward with it.
All right, we'll do that. So next Thursday ends up being full. Okay. Any other comments or? Okay, thank you. Oh, we're a minute ahead. The next bill that is a bill we're looking at that actually the Senate has been looking at, but I don't think that the House has at all. and it is a patient access to healthcare services delivered through telehealth. This is not a huge bill, but what it does, and Maria Royal will be on, she's our ledge counsel for this. There is some money that providers can access to help their patients. Maria is here, so I don't have to explain the bill. But it is something that I care about very much, and I've been trying to keep it moving forward. So, Maria, do you want to, let me just say a couple words about the bill, even though I said I wasn't going to. There is money available from the federal government for the COVID that goes directly to providers who apply for those funds to help their patients access telehealth, telephonic connections with the provider. And the concern that I've had is that there are a lot of providers out there who may not know how to access those funds. And then there are a lot of patients out there that maybe need to have the access, and we want to make sure the link takes place. So this bill is an attempt to do a very warm administrative support to build the relationship between provider, Department of Public Service maybe, and then VPQHC and others who can help build the bridge with the money between the provider and the patient. I sort of hope that's clear. So, Maria, do you want to help me? Go ahead.
Sure. Maria Royal with Legislative Council. I think that was very clear. And if I'm not mistaken, was it last week or a couple of weeks ago, we may have reviewed the initial language, and I honestly, I can't recall if that was at a joint hearing with
I don't think
House
it wasn't. It was just us chickens in the Senate. But it's
okay,
good to have
thank
company.
Okay, great. I think we did maybe then just kind of review some of the funding opportunities through various programs. So the proposal, and Mark, if I'm co-hosting, I can share it. I'll try to do that now. Otherwise, the document we're going to be looking at is, I believe it's under both the House Healthcare and the Senate Health and Welfare web pages for today under my name. And right now it doesn't have a bill number. It's just draft language. And let me see if I can.
Mark, is Maria able to share the screen to put it up?
I believe Nellie just made her a co-host, so she should be able to do that. Yes.
Terrific. Thank you.
Okay, so. Okay, did that, anything up there?
We got it.
You're able to see that document, right?
Yep.
Okay, great. And I have to just say at the outset, my bandwidth is not so great today, so please bear with me. I may turn my video off just to diminish some of the.
How appropriate.
Yes.
We need to get you some federal funds.
I know. Okay, so we'll walk through this. So the proposal here would have VPQHC consult with their statewide telehealth work group. That's an existing work group. The Department of Public Service, as well as organizations representing healthcare providers and healthcare consumers, to identify, and then in subsection 1, this is really kind of looking regionally at areas of the state that do not have access to broadband and also might be medically underserved or have high concentrations of high risk or vulnerable patients or both, and where access to telehealth services would result in improved patient outcomes or reduced healthcare costs, or both. In earlier versions of this proposal, there was a real kind of a more granular needs assessment that looked at patients, do they have access? Is it affordable? Do they have the equipment, the devices? There were some concerns raised about the ability to really do that right now. So what's left here is just looking at kind of a more regional review of what the needs might be, if that's possible. Then in subdivision 2, looking at what the opportunities are for federal funding for telehealth, and looking at, are there opportunities to maximize access to federal grants through any kind of strategic planning, coordination, and resource and information sharing. So then,
can I interrupt briefly? This is Representative Page. And I just have a question about, the broadband services, for various areas of our state. Does this not fall under other bills that are being looked at, for broadband services throughout Vermont?
So that's a very good question. And I guess what I would ask for you to do is just to hold that question. It's something that our committee has discussed. Let me just say this, there are funds available directly to providers that are different from what's going on with the broader broadband planning process and strategic work at the Department of Public Service. So the goal here is to utilize federal dollars that would help improve patient access. It doesn't necessarily mean that we're going to try to build out the statewide broadband system, but it does mean that we might be able to provide a patient with a link from the telephone pole or the street to the house. And because that money is available in this in the federal grant process, so it isn't the same as the broadband work that other committees are doing or that the department is doing. It is very much related to telehealth services and
Okay.
money available just for that.
Thank you, Senator.
I hope that answers your question.
Yes, I was just wondering whether it's a kind of a duplication of the efforts on, so.
It's a good question. Maybe we hope it will be. We hope that all this will sugar off so that we get some connections that haven't been there before and people have access that they didn't have before. Thank you for that question. It's good.
okay.
And everybody else, please interrupt as we go along. I shouldn't have said we'll hold the questions because it makes sense. Go ahead, Maria, sorry.
Sure. So after looking at kind of regionally areas of the state, looking at opportunities for funding and strategic planning, then you'll see in subsection B, based on the information obtained, VPQHC, Department of Public Service, with input from the organizations representing healthcare providers and healthcare consumers, shall provide technical assistance to healthcare providers eligible to pursue available funding opportunities in order to increase Vermonters' access to clinically appropriate telehealth services. And then finally, subsection C basically just directs VPQHC to the extent possible to use federal funding to pay for some of their administrative costs related to this effort.
Okay.
That is the proposal.
All right, why don't we take that off the screen and get back so we can see who has their hands raised. Any other question? Representative Page, does that satisfy the question that you had? Okay, any other questions from members of the House or Senate? Okay. Representative Lippert.
Well, I would just ask, has VPQHC and or the Department of Public Service expressed an ability to take on this task?
Well, we have VPQHC with us, and I know that I have,
Oh, we've
rec-
heard from,
we did have the department, and we did have all the interested parties in to testify. And I received another email from Clay Purvis the other day, and he said that they're willing to do whatever necessary to help in the administration of this. So
I'm
that,
sorry,
that's,
I don't know Clay Purvis. Can you help?
he's
identify-
Department of Public Service,
Okay,
Department
thank
of Public Service, sorry.
Okay,
And Jim
thank
Tierney was also supportive, so.
Okay,
um,
thank you.
I would venture to say that VPQHC was eager to be involved in.
Right. And my question then would be, can they do it within the resources they have, or is this going to require an appropriation?
Let's talk with Catherine Fulton of VPQHC and get an answer to those questions. Catherine, thank you for being here.
Oh, thank you so much for the opportunity to join you in your discussion this morning. And Representative Lippert, yes, we currently have the statewide telehealth work group funded through the current 9416 Billback contract. It's extending into our next 2-year contract. So it has current funding support. It would be beneficial if we needed to expand the activities of the work group to have additional funding. And of course, funding that would support the evaluation of the system. We're kind of applying a classic QI approach in terms of defining the problem, create the corrective action plan, and then implement. So to the extent that it's currently supported as a portion of the 9416 Billback, we can maintain the work group. But expansion, any extensive expansion of activities would require some additional funding.
So if you were going to do the whole broadband medical link and telehealth link for the entire state, that might require additional funding.
For anyone taking that on, absolutely.
Yeah, okay. And I think that, yeah, that's, Bill, does that?
Well,
Yeah.
it just, I mean, there's an evaluation process, and that's what I hear is saying that they can support that. But then it talks about actually providing consultation to medical healthcare providers, right? I mean, that's really the outcome that you're looking for how a consultation on how to access the funds, and that's what I'm asking. Is that achievable?
So in terms, and I think the language used here and what's up on the screen is technical assistance.
Right.
We're still mining through all the details of Maria Royal's presentations on all the funding opportunities to look at, are there any funding streams that VPQHC would be able to be the lead applicant? So far, we haven't found those where we could act on behalf of and then carve out funding to support our, staffing and resources for that particular activity. But what we can do is provide technical assistance to support, and VPQHC would be looking at supporting the providers that are not already covered through a member association that's applying on their behalf and shepherding that activity for their members. We'd be looking to provide the technical assistance and support to, more independent providers that may not get caught up in other efforts.
I see. Any other questions here by anyone? All right. Yes.
Maybe Senator Lyons, just to reinforce that Department of Public Service is a very active partner and component of the work group, along with the other member associations. And it's, as you have the member list, extensive partnerships in our true team approach to address this activity.
Thank you. You know, one of the things that a few years ago, I went to the treasurer's office and I said, do we have, we should be putting together a program between, for bonding with the treasurer's office, a VEIC, Department of Public Service for some weatherization work. And lo and behold, the people and VEDA, Vermont Economic Development Association or group, the people that came into that room to meet had never met together before. And so the result of that was a very robust discussion and opportunity. I'm hoping that by doing this, that we can build some relationships, especially between the Department of Public Service and our medical providers, that ultimately will benefit patients. And I think it is a new way of looking at access and building telehealth. So it's a little thing, you know, and even if we get one patient linked in with one provider, I think we'll have accomplished something.
Yeah.
Any other questions? Yes, sir. Representative Page.
Yes, a couple of other questions. Who are the organizations that are going to be representing the healthcare providers and helping with the technical assistance? It's not the providers that are going to be putting together these grants, are they? And how difficult is it to submit a grant? You know, submitting grants is not an easy process, and with my limited experience of it. And anyways, I'll just leave it there.
Catherine, do you want to respond to that?
Certainly. Shared sentiment on the grant application process. We, apply routinely, and it's a really heavy lift. And that would be the purpose of trying to simplify or aggregate information to make it as easy as possible for providers to access the appropriate funding opportunities. And again, Maria Royal's documents are tremendously insightful to help support that process. But in part of the work group, not just member associations, but we have direct providers also engaging and sharing their experience and information and needs.
Thank you. Okay. Other questions? All right, terrific. Unless I hear, I think that the House hasn't seen this yet, and that's why I was happy that you could be here today to sort of listen through a little bit. Yeah. Our intent had been to make it a separate bill. Theoretically, we could add this into the telehealth bill, the store and forward that we've been talking about. So that's something that the House, we've already, Senate will have to consider that if we want to add it into the bill, or we can keep it separate. And so I'd look to you, Representative Lippert, for your comments on that and how we might proceed.
Well, my initial thought is I would just hope that it wouldn't get caught up in an appropriations committee process by virtue of being part of that bill.
Oh.
That it wouldn't entangle our other bill, because that's why I was asking the question, quite frankly, because I don't see, and I will look at it separately, but it's not clear to me that there are the resources to do what the bill sets out to do. I hear that they're looking for resources, and that VPQHC has some resources initially, but I think someone might ask, well, where are the resources to actually do the implementation? And I'm not really clear. And I would just be concerned that it might entangle our other bill into an appropriations committee question. That would be my
Okay,
concern.
Okay, good concern. I'm going to turn to Catherine in a minute. I think we had heard, Catherine, maybe correct me if I'm wrong, that you have the capacity to help with the coordination activities in the bill, and it would not require additional appropriations. So I want to be clear on that, because if it goes to the appropriations committee, it probably will not see the light of day. But I mean, I can't answer that.
Yeah.
But so your comments on Representative Lippert's concerns.
And for the established charter that the work group has worked on, it in its current state is, number one, very messy. It's been worked over heavily since the onset of the COVID activities. But we have an established charter that will be approved by the work group. The scope of that charter we can manage in terms of the facilitation, the ongoing facilitation of the work group, and I would say strong set of activities, but going much beyond outside the scope of the charter as it's currently envisioned would be taxing for the organization. What I'd like to do, as I said, the charter itself is a very messy document right now. I'd like to clean it up and share the unapproved version, but it covers, it addresses a good portion of what you've laid out in this bill language. And, you know, we look to define the scope of the problem and appropriate corrective action plans to implement to help address the barriers, with many barriers to access, and we want equitable access across the system, and then work with our partners to implement the appropriate actions, and then study, reevaluate, and take corrective actions again. A classic QI improvement process.
So I guess the question is this, with the current charter that you have, you've said that much of what's in the bill is covered within the charter and is doable. I guess what I would like to know is what is in the bill that is not doable under the charter. And if there are additional funds that might be required, I would feel that a slower start than trying to do everything and also look for money might be the place to go with this. So give that some thought, please. And Representative Christensen has a question.
I'm concerned, listening to you talk about charter, that the group will get so entangled in getting the charter that the actual practical question is, going to Representative Page's concern, who is going to help the provider get this money? It seems like a very practical solution that you should be looking for. Who's going to help the provider? It's hard enough to get them hooked up, but then to go look for grants to do this, I mean, that's a lot of work to put on the provider itself. Some of these are small doctors, independent doctors.
That let me say something before you respond, Catherine, and that is exactly why I wanted to do this, because providers, there are some large providers that can automatically, they even have grants people who can go after the money that's there, but it's the smaller folks who can't do that. And so this allows for that to happen. So
Right.
Catherine, go
Right.
ahead.
And Representative Christensen, what we have created currently is a very a one-pager description of a potential pilot that we're calling the Connectivities Care Package, so that working very directly with providers who can identify a number of their patients that could benefit from a kit bag, a little bag that would include potentially a screen, ISP, internet service provider minutes and connectivity, or a Wi-Fi hotspot, plus a combination of 2 learning sessions. One, how to assemble and actually use your equipment, and then 2, how to engage with your provider through a screen, is a potential pilot project that we've put together. We've collaborated with the Medical Society to send a survey to providers with a fairly substantial response to date, to form that up into hopefully a direct into the hands of both providers and patients to address some of those connectivity issues, and being able to optimize some of the available funding with a small project like that, but then also partnering with the member associations to identify gap areas, more independent, more isolated providers that could use a little more of a leg up in getting some of these dollars directed to them.
My last comment is, I just think simplicity is probably at the root of what you should be looking for. That's it.
Good comment.
Absolutely. Yes, absolutely agreed. And the development of the charter is, for the most part, really finished. And it's a forming and guiding document that always kind of comes back to as a touchstone as the project continues to roll forward. It is not a burden to develop and maintain, but it is a living document to help guide the work and support decision points. But I agree, absolutely, simplicity and efficacy.
So I'll go back to my other question, and that is, can you simplify, are there things that we could simplify in the bill that would ensure that under the current charter that you can make the linkages and work with folks in a way that we've been discussing?
I think that, it's fairly straightforward. It may just, in that section 1 area, not having access to broadband service that are also medically underserved could just be maybe further boiled down to, a foundation of equitable access to Vermonters and providers, as and removing the barriers, identifying and removing barriers to foundational access.
Maria?
Yes.
So good. Perhaps Catherine, you could send your recommendations on that to Maria. That would be helpful.
Hello?
Sure.
Hi. Okay, so Catherine's going to send you some modification for section 1.
Okay.
And that, I think, will be an improvement.
Okay.
Thank you.
Great.
That'd be good. Okay, any other questions, committee? All right, so Bill, are you interested in, is your thought to keep this a separate bill? Do you want to wait and see the next iteration? We're open.
Sorry, I was muted. Let's see the next iteration, but I guess I just want to be really sure that we're not basically setting an entanglement with appropriations, because I really don't want that to happen.
Maria, do you think a fiscal note on this thing would be helpful? Or is it something that's probably unknown? I don't know.
I can certainly ask JFO if they can do a
Okay.
fiscal note.
Okay. Terrific. All right. Any other questions on this one? Okay. Wow. We're so early. which is our tradition, but I have seen, I want to, before we decide to take a break, because our committee has another topic that is really just relevant to the Senate at 11:15. Mike, I see that Nissa James, you are on the call on this. I think you're on are you on telephone or Zoom? I don't know, but we have had a lot of discussion around store and forward and telephone. And I think that I heard, I haven't read yet, but I understand we've gotten an email from Diva regarding telephone. Nissa, are you able to give us some comments on the telehealth bill that we were looking at earlier on the telephonic extension of emergency rules for relative to Medicaid?
For the record, this is Nissa James of the Department of Vermont Health Access. And yes, I am on the line, unfortunately by audio only, but I am here. I just want to clarify, there was a reference made about DVA proposing an interim plan for store and forward. That was actually what came over electronically yesterday evening. I'm happy to provide comments on telephonic as well. I just want to make sure I understand what the committees are looking for.
So our Ledge Council, who is not here with us right now, but our interest as two committees is to extend coverage for telephone medical service delivery until June 30th, 2021. So we're interested in extending that emergency order or whatever, it's not emergency order for you, but it is what Medicaid is doing currently for telephonic coverage and reimbursement until June 2021. And so the question is, can that happen? Is that happening? What's DVA thinking about that? And what's CMS thinking about that, if there's any information?
Certainly, yes. So regarding telephonic coverage, I just want to step back for a second and make sure that everybody has a common understanding. So before the emergency, the Department of Vermont Health Access was providing coverage and reimbursement for evaluation and management services when provided by telephone. That's a certain set of procedure codes that a healthcare provider would bill. And the reimbursement was lower than the reimbursement provided when an office visit was in person or through telemedicine, as an example. DVA has provided coverage and reimbursement for those codes pre-emergency, during the emergency, and will continue to provide coverage after the emergency. There are no plans to make any changes to those codes. So in terms of telephonic coverage and concerns about any gaps, as you look at the different pieces of legislation, those will remain in existence. I think in terms of the continuing coverage that the Department of Vermont Health Access implemented specific to the emergency, what we had stated last week in testimony is that CMS has been very clear that their changes regarding audio-only service delivery are specifically tied through the authorities that they are able to implement flexibilities and waivers through to a declaration of a public health emergency. And so in our submission for approval to provide telephonic coverage and reimbursement beyond what we were previously providing, it has been tied, analogous to what the federal government has done, to that state of emergency. We do not know what decisions CMS will make as the emergency potentially ends. That is still an unknown. What we do know is that CMS has provided an expansion of coverage for what services can be delivered by audio only. It is a narrow set of services, and it is those audio only telephone evaluation and management services, and the also expanded coverage for counseling and educational services. And they have a specific code set that can be referenced, and I'm happy to share that information with anyone who would like to see it. One of the components that they did for the period of the emergency is those audio only telephone evaluation and management services that, again, Vermont Medicaid provided coverage and reimbursement for before the emergency, during the emergency, and will continue to provide coverage for after the emergency, is that they changed the reimbursement rate at the federal level to increase the reimbursement for those services to be the same as if the service were delivered in person or through telemedicine. And so their coverage for audio only services has been much more narrow than what Vermont Medicaid released as part of its emergency response, in part because we didn't have the federal guidance at the time that we were making decisions to ensure that Medicaid members had access to care and their providers were supported in offering that care in the early stages of the emergency. So let me stop there and see if that provides kind of a level set.
Okay, I think what would be helpful if we could have some of this in written form so that we can be clear as we're making decisions, because there's a lot there. Let me try to unpack it a little bit. So what we're hearing you say is that Vermont Medicaid has covered telephonic for a couple of instances of evaluation, for example, but the reimbursement rate prior to COVID was slightly lower than what we would see in the office, and that during COVID that coverage has continued for Medicaid, and the intent is to continue post-emergency. But what isn't clear to me is what role CMS decisions will have on the ability of the state of Vermont to continue. Is CMS going to be making a change to the rules that we will be allowed to follow?
So their guidance as released and even as expanded is much more narrow than what we had approved to be delivered during the emergency by telephone. And so what we expect is to be asked that what our coverage is aligns with the guidance that they initially released and then updated to expand. And so my concern, just to be really clear, is that what we have released for being pre-approved during the state of emergency to be delivered by telephone with the reimbursement being the same may need to be narrowed so that we are in alignment with federal guidance.
Okay, and do you have any idea when that new federal guidance is coming out?
We don't. We only have what the guidance is through the state of emergency. We do not know what they will change looking forward.
Okay. Does our waiver include anything on our more expansive coverage? Does our 1115 waiver speak to this at all?
We did apply for approval to make sure that the services that we were going to be delivering through telephone during the emergency would be approved, but that was tied to the state of emergency, and so we would need to request approval again.
Okay, that answers that question. I got that one. Nissa, is it possible that you could send us something in writing, some testimony in writing that would help us be clear about where we are with this?
Certainly. So in the PDF that I sent to both committee chairs, copying the committee assistants on it last night, there's actually a slide within that presentation. It's slide number 7. And the
Okay.
title of it is Response to Draft 1.1, Section 2, Coverage for Healthcare Services. And so the first bullet indicates that we've really attempted to model our rules after federal regulations and guidance, and that during the public health emergency, CMS released updated guidance that expanded out that audio-only coverage. And so then in the next section, I actually provide the link to the exact codes where CMS has indicated that an audio-only interaction will meet the requirements. I did not send it to all of the committee members for each committee. I'm happy to do that as well.
Why don't we do this? I do apologize. I did not see that email for some reason. I don't know why. I went through a lot this morning. If
There's a
you
lot
don't
there.
mind sending it to Nellie Marvel and Demis Martin.
Certainly.
And then
Yes.
it will be posted on both web pages. And in the meantime, please, when you do that, send it to both committees and we'll have it to go through. Because and I'm really sorry that we missed that, because we could have had this information earlier in the day.
I
No
haven't
worries.
seen one either.
Senator
to the whole
Ingram,
committee. I haven't seen that email either, if it was sent to the whole.
I don't think you got it.
Oh, okay.
I think it was sent to Bill. Did you see it?
I think it came last night, and to be quite honest, between last night and 9 o'clock this morning, there were other things happening as well. I could see it was there, and I did not get a chance to review it fully.
Okay, so Nissa, thank you. I'm glad that we've got that, and it will help us a great deal. Sort of sort through the forest. Appreciate it.
So could I ask Lisa one
Definitely.
question?
Yeah, please do. Let's open it up for questions and for clarification.
And maybe I don't understand enough to even ask the question fairly.
That's the way I was feeling too. So
yeah. So if I'm missing this entirely, Lisa, just say, be candid and say so. But what I'm trying to sort out is that so there was telephonic in a narrow frame previously, currently, and intending for the future. And then for the COVID emergency, Vermont Medicaid, added some expansion of telephonic, including, well, some expansion. I'm not entirely sure I understand all of what it expanded to, but then, and that was before there was some additional federal guidance that actually expanded it further than what we did, or more narrowly than what we did.
When the federal guidance was released, it's more narrow than the services and provider types that we had indicated.
Okay, but that didn't require us to pull back, or did it?
We have not received an indication from the federal government through our partners that we need to do that as of yet. Once the emergency ends, that's when we would anticipate needing to narrow what we've specified for coverage for both services and provider types, so that we're in alignment with federal guidance. And that's my hesitation when we use a term like, we should continue the telephonic coverage status quo as an example. I'm concerned that we won't be able to meet that requirement.
Okay, so so that was all trying to get an understanding of what, if I had an understanding of what was what. So my question really then is, for Vermont, for DVHA, what would Vermont Medicaid prefer as its policy position on telephonic coverage going forward? Not what you think CMS will let you do or let us do, because it's really all of us. But is there a policy position as to what Vermont Medicaid would advocate to have be the position going forward, or has that been established? Because what I'm hearing is that, well, we did more and CMS may not let us do more. What would we prefer to do if we could articulate it for Vermont Medicaid? Has that policy position been established?
That's currently under discussion for specific details. What I will say is that where we find alignment with the perspectives that have previously been shared by stakeholders today is that we agree that coverage and reimbursement for services delivered by telephone should continue. The specifics of those are what we're working through right now. And that, I think, was, to my understanding, part of the intention of establishing the work group.
That is part of it. Bill, I'm sorry, were you finished? Okay.
Yeah, but I was just trying to get a sense of whether,
Yeah, and that is part of it. I think our concern is maintaining some consistency while the work group is working, and then before any further legislation is necessary. So I think we'll have Jen Carby probably be in touch at some point, and we'll sort through what we can and what we can't do relative to you, DIVA, and under federal regulation.
So
Go
just,
ahead, Bill.
can I clarify? So it's, ultimately, it's really not up to us as the state of Vermont or DIVA to be able to say, this is what we want to do. It requires CMS approval if we want to have matching federal funds. I mean, if we wanted to do it all with state dollars, I'm sure we could. I mean, I'm not even really sure, but really what we're talking about is to go forward with the kind of match that we get for Medicaid. We have to have CMS approval. Is that correct?
Right, and that's why I asked about the waiver and whether or not any of this is included in the waiver. So, I mean, so we'll have to look and see what is in the email and the information that NISA sent. And then if we want to go further at some point, and I'm thinking that going further actually might depend on what the working group does. Then we would say to DIVA or to the AHS, let's open up our waiver and add additional stuff in the waiver. So there's a lot
But you still have to get CMS approval to.
That's the point.
Ultimately,
That's what I'm
CMS
saying.
has to.
It have to go to the federal government, and so it's not. And so whatever we do has to be within the federal guidelines. You can't just go and do it. And I think that's.
Except with state.
That's always fun. Representative Donahue.
Well, just wishful thinking maybe, or articulating, if we end up going that route where we're trying to broaden it in our waiver, that is in theory the kind of opportunity that we have under the all-payer model agreement to get Medicare also in line with a consistent approach, even if Medicare isn't doing it for anybody else. So
good idea.
We can wishfully think that way, that maybe we could get there as well.
That's what we call alignment. That's what we want. We're all for it.
Well, good point. We should make sure that possibility gets explored.
Yes. All right. Nissa, is there anything else that you would like to share with us while we have you?
The only would be the clarification around the store and forward, if that would be of interest. If you want to hold on that, I'm happy to hold on that.
No, go right ahead.
Okay, so in the PDF that I sent over last night, and again, I'm happy to circulate it to members of each committee and then also copying the committee assistants. I tried to clarify the store and forward questions that we had from last week and really break it out into the two different forms of store and forward, one being the patient to provider, and that's the one we had a lot of conversation around last week, that we had begun that coverage retroactive to the beginning of the state of emergency, so March 13th. The second part is the provider to provider store and forward, and that's where there was a specific request from both committees, to my understanding, that the department look at being able to provide coverage and reimbursement for 2 specific procedure codes in order to meet that provider to provider store and forward, which is referred to as an interprofessional consultation for those codes. And so that's 99451 and 99452 that had been mentioned last week during testimony. And so in the email that I sent over last night, I had proposed for the committee's consideration that the department provide coverage and reimbursement for those 2 procedure codes beginning on July 1st. And this allows us then to be able to post it on June 1st for a 30-day public notice, and then begin the coverage on July 1st, 2020 for those interprofessional consultations. And then our subsequent request is that we would like to be able to report when you return in January on the data that we've collected from claims paid so that we can evaluate the effectiveness of that approach and be able to embed that information in the annual report we submit on behalf of the Clinical Utilization Review Board.
Wow, that sounds terrific. So let me clarify that beginning July 1, those 2 would go forward. But there's no end date to it until and unless, how would that work? It would
Nope,
just continue.
no, there would be no end date. We would want to review the effectiveness from the data that we have available at the time that we would issue that report with both committees and determine, if that approach is something that we want to continue with. But from our end, there would not be an end date.
That's absolutely terrific. Thank you for bringing that proposal to us. I wish I had seen your email because I just want to tell you, this is one of the things I've been worrying about since the last time we met. And so thank you. And thanks to the whole team at DIVA for putting that together.
Yeah,
Really great.
I want to just express my appreciation for the responsiveness to our committee's concerns as we articulated them the last time we were Zooming together.
That's
Thank you.
awesome. So now I can't wait to get to my email, which is a really unusual thing to say. Huh. Okay. Any other questions for Nissa?
So I would ask
Okay,
Nissa,
go ahead.
what do you need from us? Or do you need anything from us in order to, you're putting that forward as a proposal. You need to post something 30-day notice on June 1st, which is coming up soon, really.
Yes.
And so do you need some kind of affirmative statement from us for DIVA to feel able to go forward with that proposal, or what do you need?
I think that would be helpful, truth be told. So if the committees would be willing to do that, yes, we would appreciate that.
So
Bill, I think what we should probably do is to have Jen and communicate with Nissa on this one and get.
Well, should we all? I mean, so again, if I may, Nissa, if we were to give that affirmation or affirmative support sometime next week, is that soon enough for you to post something on June 1st, or do you need something today? Because
no, we'll start behind the scenes so that we have everything ready to go pending your affirmation.
Because I'm guessing we would likely do that, but I think we ought to be able to all review the emails, which we haven't had a chance to review, before we just say go forward. I personally would be prepared, but not everyone has seen that, and I think we just want to make sure we understand what it is that's being proposed fully.
So then what I'm hearing then is that we should be sending a letter to DIVA. Is this a letter that you're looking for affirmation?
Yes, that would be perfect.
Okay, so that would require Ledge Council to and you to communicate so that we know that we're not saying the wrong things.
Right. Maybe we could have in the interim between now and our next joint meeting, we could have some work done on a draft letter for our consideration, based subsequent to us reviewing all the emails, et cetera.
I will, when we get back on our call today with Jen before our next topic, I'll bring this up.
Okay,
and
great.
You can stick
That'd be-
around if you want, but Nissa, thank you for that. You saved the best for last. And I see every representative and senator smiling, so you've done us a good service today.
Oh, thank you so much. I really appreciate being able to provide testimony. Thank you.
All right, terrific, thank you. Any other comments or questions from the committees? Okay, no, okay.
But we'll just need to make sure, that providers know that Medicaid will be reimbursing for that.
Oh, that's why that 30-day notice is going out. They'll be, I think, you
Okay,
know,
well,
yeah. All right. Our committee is doing some discussion about some Senate work that's going on with Senate task forces at 11:15.
we'll try not to listen.
And so anyone who wants to come back and join us, you can do that. I think, where's Mark? Nope. Where's Mark? Nellie.
He's there.
Okay.
People move
okay.
around on these screens.
I can't find anybody. So what we'll do is we're going to take a little break until about 10 after 11, 11:15. And then we will come back as a committee. Jen Carby will be here with us. And anyone from the House who is a glutton for punishment is welcome to stick around. I see two hands up, Dick McCormick and Brian Chena. So Senator McCormick, you're first.
Thanks, Madam Chair. I appreciate a break. When we come back, I would need maybe 5 minutes to discuss the amendment to S-295, just so that I can say on the floor that it has the support of the committee. It's a very simple amendment. It was basically a Scrivener's error, except it's a Scrivener's error that changes the meaning of the bill. So
right. Okay.
We have to do it as an amendment.
That could be important. Okay, thank you. You definitely have that time. You definitely have that time.
Thank you.
Representative Chena.
Thank you. I have a question for Chair Lipper.
Yeah,
it sounds like we've been invited to observe, but I'm asking you as the chair of the House Committee, what's your expectation for us for the rest of the day?
Yes, I was about to clarify that for our committee. Thank you. I would suggest, since we have also a separately scheduled House committee meeting, I believe at 2:00, and it's scheduled from 2 to 4. My expectation is that you take a longer break, and that based on what I don't know a lot about what the discussion that the Senate's going to have, but I think that our committee could simply sign off and then reconvene at 2:00 as the House Healthcare Committee at 2:00.
I think you'd probably be wise.
Right.
Wise decision.
Because we have to come back as it is.
Yeah.
Just to jump in for our committee.
Yeah, where are you? Or you're somewhere on the screen. I can't find you. But go ahead.
So I just want to mention.
There you are.
Since we've got a little bit of extra time, to the extent people can, the miscellaneous bill is posted, so people might want to try to take a look at it in advance.
Take a look, yeah. Yeah,
Yep.
Good. Thank you, Ann. Because that's what we're going to come back to at 2:00. And Jen will be with us at that point. Okay.
Okay, so for senators, do not leave Zoom, but you can mute yourself and take your video off, and we're on break until 11:15. So thank you all. It's been a great day.
Thank you, Jane.
Bye, everybody.
Yeah. Hi, Debbie. I have a quick question for you. You're muted. Okay, there you are. Do we know what bills we're doing on the floor today? Did we get an email on that?
No, yeah, I was just thinking that, Jenny. I was like,
Oh,
could somebody tell
I'm
us?
not
what-"
gonna worry, not worried about it.
Yeah.
The
Yeah.
other one is, I gotta write this one down. So we have these questions from Allison.
Yep.
Let's try and do it assiduously. I mean, quickly, efficiently. That's what it was.
Okay. Yeah.
And
Yeah. Okay.
Jennifer.
I'm back. Thank you for your patience.
Okay. No, we got to take a break.
Oh, good.
So listen, when you weren't here,
There's cake?
No. Who has cake?
Senator Ingram has cake.
I got a snack.
Is it cake? Oh no, is
It is cake.
Oh, it is cake.
Yeah, it's
Okay.
cake. It's cake, and I put bananas on it. You know,
Oh,
I like the Hannaford Bakery. Just my local Hannaford. They always have me little things that I like, and they're inexpensive. Who needs to go to Mirabelle's when
I can't remember?
And are we,
Yeah,
it looks like we're
no,
on
actually-
YouTube. Are we back on YouTube? Just so everyone's aware.
We've been on the whole time.
Well, I think you were on pause for a bit.
I just did a good advertisement for my local grocery store. Then
That's where we got your birthday cake when we had your birthday last fall.
yeah, oh, that's good. Yeah, it was a good cake.
They do a good job. Jen, we had some testimony at the end of the meeting from Nissa James of DEVA.
Okay, I can go back and watch it.
Well, very quickly, they are interested, they want a letter of support they're gonna take public comment on adding the 2 codes, the store and forward codes for Medicaid. And they want to do that as of July 1st. So they're looking for a letter of support from the 2 committees. So you can just link with her and she can help write the letter.
Okay.
Yeah. We were thrilled that they want to do that. That's good. That's all you missed. Well,
Great.
And then, well, also, she sent an email this morning to you and me and Lippert. I didn't see mine, so I didn't know that information.
I was included on it.
Okay.
Oh, I think actually that Dennis had shared it with the healthcare committee.
Yeah, we hadn't seen. Well, I didn't see it. So
and me.
Okay, so we should post that up on our webpage. Well,
Okay.
Nellie can do that.
Yeah, it did go to. It looks like it went to Nellie. It looks like it was sent Nellie yesterday at 4:36 p.m.
Why did I miss
You're
that?
looking for it.
I'll look for it. I'll send it. I'll
Okay.
send Nellie a
Otherwise,
note.
do you want me to? I can just forward it to you right now. You want me to forward it to you so it pops up in your email?
Sure, that's good. We aren't going to talk about it right now, but I'll help.
I'll copy Nellie too.
Hiya,
All right.
kids.
Hey, okay. Well, Senator Westman has a board meeting, so he's not going to be here.
Okay.
Who is Cindy?
It's Cindy Brzezzi from Vermont Ethics Network.
Ah, there you are. Oh, how are you?
I'm well. How are you?
I'm well. So we probably aren't going to talk about H950. Is that what you were anticipating?
Yes, that's what I was anticipating. But if you're not going to talk about it, then
Well, you know, we might, it might eventually get around to it, but we've got another thing we have to do. Senator Cummings?
No, just tomorrow morning at 9, I have a short VSAC board meeting. I
Okay.
think you're on at 9:30. I
I
think
think
I'll
we
be
are on
back.
it. We're on at 9:30 tomorrow. Yeah.
Okay, I should be
Yeah,
back. I may be back. It's just a bond approval.
Okay.
But in case I'm late, that's where I am.
Okay. Not a problem. Yeah, things are starting to get busy in a different way. So I have a list of about 5 or 6 things to look at. One, I just mentioned it to Jen, the letter of support that we want to send out from both committees to DEVA. This then.
What?
Did somebody say something? No.
What was the
Okay.
letter of support for?
Oh,
Sounds like it's for their proposal around
Store
going
and
forward with
Forward.
store and forward for provider to provider information, transfer of
Right.
information.
for consults and provider to provider discussion. And there are 2 codes that relate to that. And they want to have a public comment period for the month of June. And then have that go forward. So there will be reimbursement for providers for store and forward through Medicaid. And which is really good because it brings it more in alignment with what's going on with private carriers. That's it. That's the letter. We'll be able to see a draft of that, and then we'll make sure it gets to DEVA before June 1st so that they have some support. Then number 2, here's what we're going to go through. We're going to look at some questions that came to us from the task force that Becca and Randy are leading. Then we're going to look at the bills that we looked at yesterday and decide who would like to pursue those bills, if we would like to, which ones you're interested in. And then the next thing we're going to do is Senator McCormick has a proposal of amendment on S-295, which is really a technical. So we'll have him talk about that, and that will be probably it. So let's start. We were, as I said in an email, we were asked to go through some questions from the task force, and Senator Ingram is going to be taking notes, and she's also going to help me if I forget to ask a question or doesn't think we've answered it thoroughly enough. I did send you the questions. I think I will go through them one more time. The questions are related to what's happened during the emergency order. The first question is, what did we do well? The second one is, what could we have done better? The third question is, what changes should we make to our current execution and future planning? And I see that as both committee process and Senate process. And then number 4, what do we wish we'd had in place? Number 5, recommendations for immediate course correction. Number 6, analysis of contingency planning and emergency management opportunities for improvement. And I'm not clear on what that means, but maybe it means the bill that we're working on, but I'm not sure about that one. So let's all just chip in on what did we do well. And I include in that, I guess, I include in that committee, Senate, overall process. So Debbie, do you agree with that from your perspective as a task force member?
Oh, I'm actually not a member of
And
that.
you're not on that one, but you're on the other one.
Yeah, but I would kind of maybe recommend that we sort of take different sectors of what we have to deal with. So, what would we say about, the public health public health, about hospitals, about long-term care facilities, about childcare, kind of take it by different sectors.
I don't think we can do that for everything. I'm seriously, they've got 6 questions and we've got a short
Yeah.
period of time. We've got
Yes.
15 minutes, 20
I think
minutes.
I
at
mean
the
for us
most.
just to sort of throw things out. Like I would,
Right.
the first one, what did we do well? I would say Act 91 was good, and it covered it looked at telehealth, it looked at pharmacists, it looked at
Well,
hospital.
let's just Act 91 overall. We acted quickly to build a public health and a healthcare response.
Yeah,
I think, right?
Yep.
That's good.
Okay.
What could we have done? So does anybody want to say what we've done well? What have we done well? Anything else?
I think the child care stabilization has been good too,
Yeah.
to the extent that that's part of
Are you thinking specifically, are you thinking about the entire Senate or about a committee process? I think we need to distinguish between the two.
Oh, I wasn't focusing so much
Wow.
on process as the outcomes
Huh?
that they're related to healthcare.
Okay. Anybody else want to say we did anything well? Oh, I'll tell you one I think we did well, and that is we evaluated medication issues, and the OPR is doing its job. Whatever we don't have to do helps. The other thing I think we did well, I think that we have built insight into all of the areas of healthcare and human services, which includes childcare, long-term care, etc.
Okay.
Ginny,
Uh-huh.
could we say we kept the safety net in place? That all of those human service, healthcare, that we were able to maintain that and expand it as the need arose.
Yes, I like that a lot, and that because it does it brings to mind folks dependent on our designated agencies.
Yeah.
Among other things. Very good. What else? What could we have done better?
We could have done better with collecting race data. We discovered.
Also, right, but I think our testimony helped build that dashboard.
Yeah, that's true. Mhm.
I think we can say what we did well was we encouraged the collection of race data.
Mhm.
And it could have been done better in the beginning.
Yep.
Right. Shouldn't take us to make it happen.
Ginny,
Yes.
I don't know if it's us or that's probably us. We didn't have an emergency management plan for childcare. We kind of flubbed, with, well, the teachers will do it and we'll keep the schools open. We didn't have, this is what happens with childcare. Like,
And this is when
this is the
people go back to
emergency shelter.
what
This
happened.
is where you go when the flood happens.
You know it. Yeah. So there wasn't a plan.
Right.
What could have been done better?
Not an emergency.
There could be an
childcare
emergency plan in place, right, for all of these areas, but childcare is a big one. We're going to talk about that tomorrow. That's huge. Oh, excellent. What else?
Well, I guess like PPE wasn't everywhere it needed to be at first either, was it?
Yeah, and it's still going to be problematic.
Yeah.
Every person in the state should have access to their own little face mask. My daughter gave me a face mask yesterday. It's beautiful. I've been using a bandana.
Accessory, you know.
Anything else that we did well?
I
or we
had a
could have-
dozen, but they're all gone.
Yeah, no.
Grandkids arrived. They're
Uh-oh.
gone.
Uh-oh. Anything else that we could have done better? Okay, what changes would you make to our current execution and future planning? You know what we could have done better? A little bird just told me. We could have more a statewide purchasing program for PPE and other things. Definitely as part of that. That doesn't have to happen in an emergency either. It can save money going forward. But yes, that's an excellent suggestion.
Do we want to say domestic purchasing program?
Sure.
Because a lot of the issue has been that this country as a whole was purchasing from China.
Yes.
And
I like that. Cool. What else, Senator Cummings? You've got a lot. Anything?
And I'm
making
going back to
changes.
my flood day.
I
In the flood
know.
day, we learned we didn't have an emergency planning for schools. You don't just release middle school children into a flood. This one, I think we moved it down a notch to childcare.
Yeah,
we didn't-
very good.
We haven't updated our thinking that childcare is an essential service. So
Excellent. Yes.
think there we are.
Hugely. And one of the things I think, what could we do better in the future is ensure that the safety net and childcare workers, that our frontline workers, our essential care workers, childcare workers are paid commensurate with the responsibility they're taking.
Yeah, that's ongoing.
That is ongoing. And I jumped down to the future planning piece because I also think, what could we have done better? I think we could have had a budget or a payment program in place for our hospitals that would have stabilized them better through the emergency. I've recently been doing some research on global hospital budgets. And in the state of Maryland, where they have a global hospital budget, the hospitals have maintained financial stability much better than where the global budgets are non-existent. So I'm very interested in moving forward, FYI, on global budgets, and maybe that'll supplant some of the things we've been seeing in that bill that everybody doesn't like.
Oh, I know something, future planning,
What?
or something we haven't done well, is we are still going to have a lot of the usual jerry-rigged childcare for school-age kids this summer.
Oh, gosh, yeah.
Many of those programs, we don't know yet if the rec department is open their day camp. That is a major childcare provider for central Vermont for school-age kids. We don't know what we're doing with those kids this summer. But
Yep.
we know we want their parents back at work.
Yep. And that's another issue, actually, and that is stabilizing family relationships and available care for kids. But it's also, we've had 2 parents working remotely, taking care of their kids.
Yeah.
I don't know what you do about that, and I don't know how you help with that, but maybe that's
We
a,
are also going to need a lot of dog therapists when all these people leave and the dogs are alone.
oh, I know. I mean, that's already happening.
There will be a great deal of acting.
What about cat therapy? Is that going to happen?
I know my
cats don't
cat
care if
is
you're
gonna
here or
freak
not.
out because
They
my
want
niece
to-
is moving. My niece is moving out. She found a new place, so he's had both of us here all day long for weeks, and it's bad.
She is going to be, she's going to need therapy. I agree.
That's right. No warm computer to climb up on and
That's right.
Well, how about the notion of therapy issues and
Yeah,
mental
mental
health?
health.
we don't know that yet.
We don't, but it's gonna.
Oh, yeah.
And substance use too, because
Yeah.
our sales have gone up and all that.
Yeah. Oh, yeah. Alcohol sales are up, way up. Okay, we'll keep going. And then as you think of things that you'd like to throw into any of these categories, let me know.
Yeah.
What do we wish we'd had in place? Oh, I wish we'd had in place paid family leave.
Mm-hmm.
I wish we'd had in place global budget, hospital global budgeting, a more comprehensive all-payer program.
Mm-hmm. Universal primary care, so no copay.
Okay,
Yeah,
yes, that.
this,
de-
it may
definitely.
be, I wonder if it's too ambitious an answer, but this is not writing law. This is simply analyzing a situation. I think the idea of universal care, the absence of that really has mattered here a lot.
Yep. Okay. Yes, that's a very good
That would
comment.
probably be a study that we should do, though. Did people in fact not seek care? I mean, I don't know that we know that, but are there people who, and the Department of Health should be running those, did people not seek care? Did that
Yeah.
spread? It would be the big thing. If you don't go get diagnosed, did that
Yeah, but
contribute to spread?
But it's also the fact that because of the epidemic, optional, what's the word, these surgeries or treatments that are elective have not happened, and that's putting the hospitals and the providers in economic jeopardy, because healthcare is a business, and maybe it shouldn't be a business at all.
That was Senator, that was number one on the list that I sent out to the other task force, that healthcare is a business. And we're talking so much about reimbursing business, and healthcare businesses are not included. And that's the independent practices. And we've got to do something, or we're going to lose the people that we have.
Well, I'm representing a community, Springfield, whose hospital is in bankruptcy.
Yeah.
Companies go into bankruptcy, not public service entities.
So I have two other things I wish we had, what we wish we had in place, and probably future planning. But one of these things I think that the federal funds could help, and that is data collection. Our system in AHS and our system, which includes the Department of Health, probably has the best data collection system, but we need the IT and the software and the data collection system so that we can compare and contrast with within agencies and outside of agencies. This is absolutely critical during an emergency, but it's also important when we're not in an emergency. And so interfaces with various healthcare facilities, organizations, just think of the scope of what we have and what's needed. So that one, data collection, and that all falls down into the area of IT. And then the other question I have, which is,
Well, overall,
huh,
the importance of being up to date in technology.
yeah,
And we don't spend any more money than you absolutely have to. And when we all know we had an inadequate system and it was the computer system. You can always hire people to answer phones, but we had an inadequate computer system. There's probably other places. I know we've been working on that one entry at AHS. I don't know if that caused problems. I know I've got one constituent who's been having a lot of problems between unemployment and child support, because child support was getting taken out in both places.
oh, wow.
And I mean, this was a person who was paying and wanted to pay.
Yeah.
But the computer systems couldn't get it straightened out.
So, and that actually brings up another issue that it's UI related. It's not related to our committee, but it is a frustration that I've heard from some of our little independent small businesses who sometimes contract with other businesses. So they have both W-2 and 1099s. And as soon as you put a W-2 in, you're stuck in the UI system. So I know some guys, one in particular, who owns his own business. He had a minority of his income from W-2, and he's stuck receiving the lowest amount. So he's not getting reimbursed anywhere near what other people are. And so Debbie, write that one down. We need to fix that. If the whole point of paying people during this emergency because they can't work, pay them for what they would have earned, not what the requirement is outside, for UI.
Right. But UI is set up for working people who get laid off.
Yes,
it is not set up for independent contractors contracting with each other. Yeah. I had a lot of emails at the beginning with people who did consulting business, but the people they were consulting with weren't working, so they had no business. But the question was, are you available to work from home for money? And they said yes, and they were disqualified.
I know. Yeah, no, I know. And if you say you have a W-2, then all of a sudden you can't claim your other income for unemployment in the time of an emergency. Did you write that down, Debbie? Good thing. It's bothering me for those guys. I have another two other things for going forward. Okay. Going forward, if we look back, we want to know who's in charge. Right now, the governor is issuing executive orders. And we've been going through this process, but obviously the Department of Health is critically important, and we also have economic input that's critically important. We want to ensure that going forward, we continue to have this very collaborative, integrated approach to leadership in the state. It's a product of the people right now, including us. So I think that the question of who's in charge and how the decisions are made becomes pretty important. And I know that in an emergency at the local level, it's the public health officer or the fire chief who gets put in charge. So we'll just have to
It's
we need
whoever's
to
been
sort
named the emergency management coordinator.
coordinator.
Yeah.
So that, as we look at our, as we sort out our emergency planning bill, this is something we don't want to write the answer. We can't write the answer, but we can ask the question. And I think then it deserves some attention. The other question I have is, as we continue in the next phase of all of this, how do we make determinations about vulnerable workers who are working remotely, and then businesses open and they have to go back to work and they're still vulnerable? I mean, we know the surge is coming. We know the virus isn't disappearing. So the question. Okay.
Can I just ask one question that Senator Ballant wanted me to make sure we talked about, was about long-term care facilities, since they were the locus of a lot of the cases. Was there anything we could have done better?
On long-term care facility? Yeah, I think you need to, for all of these facilities, you need to have, I think some of the policies and that are put in place are things that should remain going forward. So, or at least an analysis of them should remain going forward. I think we're learning a great deal about long-term care facilities.
Mm-hmm.
The other question is, do we want to continue to have them? How can we have people, more of our older Vermonters, staying at home and provide the services they need at home? All right, what's the next question, Debbie? Do you have it?
Yeah, well, recommendations for immediate course correction. Immediate course correction, I don't know. I mean, I think the bills that we have in the pipeline are addressing some of the things that we need to do.
Well, I think immediate course correction is to analyze the emergency rules that are in place and to determine how long they should remain through a transition until we're clear, clear. We've gotten clear from the problems.
Yep. Okay.
Anything else?
Analysis of contingency plan and emergency management / opportunities for improvement.
Analysis, wait, I lost the question, hang on. Analysis of contingency planning and emergency management opportunities for improvement. Well, I would say we're working on it. You know, we need to have a process. First, I want to say we're working on a bill. I don't want people to lose sight of that, even though it seems premature. We are working on the emergency planning bill, and it does need to be a process that's inclusive and can take into account a lot of the work that's happening in the legislature, but also in the administration and in the community. So it's a very large and broad process. And as I read the federal guidance, there's a statement in there that stands out, and that is that there's money available for emergency planning. So when we write this bill, and this doesn't go in the report, but when we write the bill as a committee, we can begin to identify places that can access federal dollars to plan, to work on. So, you know, think about it. Regional planning commissions, they could use a little extra money to complete their plans. Towns, you know, others. designated agencies, long-term care facilities, they can use some money to join in with the planning effort. Senator Cummings.
Okay. We didn't have a plan in place for isolation of people. We obviously did not have a testing system in place. Now, I don't know how Taiwan did it, but they tested everybody and everybody wore face masks. So we still haven't mandated face masks in public. We were very slow to do that. We didn't have a system when it started. We had information worldwide that this was a very contagious virus. So we didn't have a plan for isolating people that were symptomatic. We didn't have any kind of public acceptability of wearing face masks to protect people because we didn't have that whole pre-planning. I gather from what Dr. Levine said, what they learned at that first nursing home was they never thought of a patient as a vector. And
yes, exactly.
So it sounds like, we didn't screen as people were being admitted. We were screening staff and visitors. So we didn't have a whole screening or testing program.
So yes, that's could have been done better. You're right. And going forward, it could be done perfectly the next time.
Yeah. I don't think we
Part
can
of what-
stockpile vaccines for a disease or even testing for a
No.
disease that is brand new. But we should have some kind of a screening, isolation. We did it pretty well with the prisons. We seem to have failed with the Bennington School for Girls, but I know we had a plan in place for state group homes. I know we were looking at Goddard, that if somebody,
right,
we got those in place. So
having what I'm hearing you say is the testing piece is important for any infectious disease as well as contact tracing, and to have those plans up front.
And screen, a whole screening and
right.
A quarantine or an isolation program, to
Right.
put somebody who's symptomatic at home with their possibly even more vulnerable spouse.
We
not
did
helping.
we did a good job with the homeless people.
We did a good job.
That was good. We've done a less good job with the migrant population.
Well, so far, do we know
they
we haven't? Because we've had one case and he caught that from the farmer.
Exactly. So they have been able to quarantine a whole farm. So
yes.
Yeah.
But we don't have a quarantine program if someone there gets sick.
Right.
And I don't know if someone the homeless are down the street from me. They're all hanging out in the stone wall, smoking cigarettes, and they aren't 6 feet apart. And they're all getting on the bus to come up there every day at 5 o'clock.
Oh my gosh.
I don't know that and no one's wearing masks. I don't know that if someone got sick at the Econo Lodge, if there's a plan in place for what do we do with them. Not
So
sick enough.
what you're saying is we need to have that plan up front where people will be isolated or quarantined.
Yeah.
Based on geographic location.
Yeah, what do we do? And what do we do with people who
or type?
Are not, they don't need to be in the hospital.
No.
But
Some
you
of them.
send them home. Where else do you send them except home with perhaps a spouse or family members who are even more vulnerable, shouldn't have the, are more vulnerable than they are? What do you do with a kid who brings it home to a parent with lung cancer?
Yeah.
We don't have that. We haven't even thought about that, I think, at this.
No, that's why I'm very concerned about our vulnerable workers and vulnerable populations. It doesn't matter whether it's related to racial and ethnic backgrounds or whether it's because of an autoimmune disease. We need to have provisions for those people to understand their vulnerability, A, but B, for employers to also support their needs until the epidemic takes its course. Well, I think we've done a lot. Do you think
Yeah,
that's
that's-
enough?
I do. I think that's good. I have a
We
phone
could-
call at noon.
We need to hear. We need to hear from Senator McCormick. But go ahead, your question.
Yeah, I was just gonna say on the what did we do wrong and right? It may be a bit of a stretch, but I think the problems with UI, the problems with things not working right, becomes a mental health problem in some cases, where you're out of work, you're trapped at home, and now you're spending hours on the phone. People start to lose it after a few weeks of that. And okay, anyway, the amendment, when this should have been on S-295, we should have done this on the amendment at second reading yesterday. But if you remember, the ban on food packaging that contains various horrible things, that ban goes into effect only if there are usable alternatives. And the language putting that provision into the bill that they have to have alternatives or the prohibition does not apply. The language as it's presently worded is cites the prohibition on PFAS, but not on bisphenols.
Okay.
And basically, it's a typographical error. It's a Scrivener's error. And I was tempted to just ask Bloomer to just correct it, except that it actually does affect what the bill will do in law if passed. And our intention clearly was to cover all these classes of contaminants. And so this just makes it do what we thought we were doing in the first place. So I would like to, I'd like to say on the floor, I keep saying on the floor, I'd like to say that that has the committee's support.
I think the intent of the bill and what we thought we passed included that proposal of amendment. So
Yes.
I support it.
You think it's proper to thank Jessica Oskey by name or maybe
No,
not?
no,
No?
totally inappropriate.
Okay.
Inappropriate.
All right.
Yeah. You can thank your ledge council for fixing it.
Yeah.
Not but council.
Huh? No.
Well,
No,
well,
she's
I
not.
mean,
But Katie
amendment-
helped.
Yeah, Katie wrote the amendment.
Right, but I just, I think just explain that this was a change from the time that we approved the bill. And it should have been included, and that's it.
Yeah.
Doesn't need to be too complicated.
I'm not going to give the Gettysburg Address on this. I'm just going to, it really is a technical fix.
Okay, good.
So it has the committee's unanimous, well, 401 support.
Right, we're good.
Okay, thank you.
All right, thank you. All right, so on Tuesday, we'll come back and we'll look at the bills that you're interested in. And we're going to start looking at the federal dollars on Wednesday and what's going to happen. So that'll be interesting. I may send you an email out over the weekend. We can talk tomorrow a little bit. So we should end now because it's been a long morning. We've done a lot of work. Thank you.
Thank you.
You've all been
Everybody.
very thoughtful. Thank you. Mark, we can we can leave YouTube. We're good. Thank you.
All right, have a good day, everyone.
Take care.